Good morning. My name is Dr. Kerry Jewell. I am a nuclear medicine registrar from Melbourne, currently based at Peter MacCallum Cancer Centre and previously at Austin Health. Today I will be presenting my advanced training research project in consideration for the Australasian Association of Nuclear Medicine Specialists Registrar Research Award. The topic of my manuscript is a comparison of FDG PET to beta-amyloid PET in persons diagnosed with mild cognitive impairment or mild dementia. This project has been approved by the Austin Health Human Research Ethics Committee. Dementia is a serious and pervasive medical condition characterised by progressive and irreversible cognitive decline, severe enough to affect daily function and independence. It is the second leading cause of death in Australia and directly impacts the daily lived experience of over 1 in 12 Australians living with or caring for those afflicted by the condition. Alzheimer's disease is the most common form of dementia, while mild cognitive impairment is an intermediate clinical state between normal cognition and dementia, which results in memory difficulties greater than expected for normal aging. However, a person's ability to function in daily life is preserved. Up to 50% of people with mild cognitive impairment may progress to dementia, but this leaves a substantial proportion who do not progress or even recover cognitive function. Early and accurate diagnosis of these separate entities is difficult, but of vital importance to people for whom diagnosis will have measurable impacts on management and quality of life. From the 1st of November 2021, FDG PET brain studies have been listed on the Australian Medical Benefit Schedule for the diagnosis of Alzheimer's disease, contingent on several criteria being met to ensure appropriate case selection. Amyloid PET is not currently NBS supported, and there is little direct comparison data available to inform its potential future inclusion for dementia diagnosis in the Australian setting. There were two primary aims of this study. The first was to compare FDG PET to beta-amyloid PET to identify Alzheimer's disease in patients given a clinical diagnosis of either mild cognitive impairment or mild dementia unspecified. The second aim was to determine inter-observer concordance rates in FDG and amyloid PET interpretation across the spectrum of skill proficiency from novice and advanced beginner to proficient, in contrast to an expert reader, to help determine the reproducibility and accuracy of results. Participants were identified from a screening program run by Austin Health and the Australian Imaging Biomarker and Lifestyle Study on Aging, or ABLE, to capture patients with amyloid positivity and mild cognitive impairment or mild dementia, suitable for clinical trials of anti-amyloid agents. To be included in the study, participants were required to meet an extensive list of inclusion and exclusion criteria as listed in this slide. These criteria covered basic demographic items such as age and suitable evidence of cognitive impairment, along with practical considerations such as willingness to freely participate in the study, no past history or comorbidities that would preclude medical imaging with PET or MRI. 237 patients met the criteria for participation and underwent imaging with both FDG PET and amyloid PET, which were performed in a random order determined by the availability of tracer and scanning slots. The studies were then read separately and at least 2 weeks apart by a nuclear medicine specialist with extensive expertise in the interpretation of FDG and amyloid PET scans in dementia. This specialist was blind to clinical and cognitive data and the results of any prior neuroimaging. The following slide outlines the protocols used for FDG and amyloid imaging in this study. 4 different beta-amyloid tracers were utilised, with the majority of amyloid PET scans conducted using fluorine-18 labelled NAV 4694. All PET scans were conducted at Austin Health or at the University of Melbourne on Philips or Siemens model scanners, and all PET radio tracers were produced in-house by the Austin Health Centre for PET. Scan acquisition time varied depending on the radio tracer in use. Scans were read from saved screens of transaxial slices. FDG PET scans were rated as positive if the pattern of hypometabolism was phenotypic for Alzheimer's disease, that is, observed in 2 or more typical cortical areas, including the lateral parietal, precuneus, lateral temporal or posterior cingulate gyrus, along with relative sparing of the primary sensory motor and visual cortices. This impression was then compared with Neurostat, a normal database of cognitively normal older persons with negative amyloid scans and a mean age of 72 years. Amyloid PET scans were rated as positive if there was visualization of increased tracer binding in the frontal cortex, lateral parietal cortex, precuneate and posterior cingulate regions, lateral temporal cortex, or striatum. Quantitative analysis was performed using the capable software developed by CSIRO, which expresses amyloid levels in a standardized unit known as centiloids. The following 3 slides show example transaxial slices from the same patient, representative of the dataset read for each participant included in this study. First, we have a transaxial slice from an FDG PET study with a pattern typical of Alzheimer's disease. Interestingly, there is some sparing of the precuneate in this example. Neurostat gives a surface display of the brain cortex, coloured by the standard deviation of each pixel from the normal scan database, in a rainbow scale ranging from 0 to 7 standard deviations. Studies are considered abnormal above 2 standard deviations, represented in the blue-green range. In this case, Neurostat confirms marked asymmetric abnormalities characteristic of Alzheimer's disease, most significant in the left temporoparietal and frontal cortices. This is also consistent with beta-amyloid PET findings for this case, which show severe tracer binding in multiple phenotypic areas, highlighted in red. There were 120 confirmed cases of 28 cases of mild cognitive impairment and 73 cases of mild Alzheimer's disease in the study cohort. For the expert reviewer, there was almost perfect agreement between visual and quantitative classification of amyloid PET as positive or negative. FDG PET showed moderate agreement with amyloid PET with a high specificity and high positive predictive value for a positive amyloid scan in Alzheimer's disease, but only moderate sensitivity and a poor negative predictive value in mild cognitive impairment. As with the reliability of clinical testing, the interpretation of neuroimaging for cognitive impairment is open to inter-observer variability. To understand this phenomenon in relation to our PET scans, 3 new readers were engaged to review the FDG and amyloid scans, again in separate sessions, and again blinded to previous clinical, cognitive, and imaging data. 3-point and 4-point rating scales were used for FDG and amyloid studies respectively. Score of 2 on both the FDG and amyloid scales represented borderline cases which were not strongly positive or negative. Fleece Kappa statistical analysis, used for assessing the reliability of agreement between raters, characterized the results on a scale from no agreement to none to slight agreement, followed by fair, substantial, and almost perfect agreement categories. Initial review of the report data sheets detected some missing values in both the FDG and amyloid datasets, which were excluded from analysis, resulting in a final dataset of 233 patients for the FDG read and 230 for the amyloid read. In the FDG image review dataset, there was a perfect match rate of around 28%, a partial match rate of 64%, and a non-match rate of 9%. In other words, in the majority of cases, 2 of the 3 observers rated the scan in the same diagnostic category. However, this means around 1 in 10 patients had scan findings in which none of the readers agreed on the rating. In the amyloid dataset, the degree of matching was very similar, with 28% perfect matches, 66% partial matches, and 6% no matches. Fleece Kappa analysis showed an overall fair agreement between observers in the FDG and amyloid datasets. The strongest findings were for moderate agreement between reviewers of negative or severely positive amyloid studies, whereas there was porous agreement when reporting suggestive or suspicious but not diagnostic FDG PET studies. The outcome of the head-to-head comparison by the expert reviewer between FDG and amyloid PET was concordant with earlier studies, which showed high specificity and moderate sensitivity. When coupled with amyloid PET, dual neuroimaging produced a very high positive predictive value for true positive scans, although the coupled modalities were less sensitive for more equivocal disease states, as seen in participants with mild cognitive impairment. The results of the inter-observer analysis of the non-expert reviewers showed less diagnostic certainty amongst non-experts compared to the expert reviewer, especially for borderline studies, which were not clearly negative or severe. This is in contrast to earlier studies which found with brief training the use of neurostatin-capable references facilitated comparable visual interpretation of scans between expert and non-expert reviewers. There are possible contributors to the fair agreement finding between reviewers in this study. Firstly, expert readings were taken from transaxial slices of high diagnostic quality printed on A4 paper. To enable blinding of the non-expert readers, imaging reviews for the inter-observer reads were conducted with digital files, some of which had been rescanned from old printed paper copies. In most instances, the configuration and visual intensity of digital transaxial slices differed from their originals, which makes direct comparison to the expert read difficult. Additionally, individual reviewers read the scans on different electronic devices with no standardization in screen calibration or color controls. If repeated, this element of the study would benefit from the use of de-identified, homogeneous printed datasets to better allow direct comparison between readers. These findings also raise multiple other questions for further analysis. In particular, it would be of use to obtain a mode for each reader and compare these values back to the expert reader to gain a sense of potential tendency towards under or overcalling the diagnosis as mapped to skill proficiency. There would also be value in further analysing the visual elements of FDG and amyloid studies that determine how individual readers categorised equivocal studies. Educational material could then be created in an attempt to further calibrate readers towards standardised assessment criteria. This may be particularly relevant as 2 of our 3 reviewers were either a novice or advanced beginner in interpreting dementia PET scans. In conclusion, FDG PET has been shown to be highly specific for Alzheimer's disease, but it is only moderately sensitive in mild cognitive impairment. However, a negative FDG PET study does not rule out Alzheimer's disease. In this inter-observer variability study, there was also an overall fair agreement between non-experts as to the scan diagnosis. Ongoing work is in progress to investigate the findings in this initial inter-observer comparison to determine the likely factors which contributed to variability so they can be optimized and eliminated in the real-world setting, helping to ensure accurate and reproducible neuroimaging diagnoses for those living with cognitive impairment. A big thank you to my supervising consultants, Chris, Andrew, Zeeting and Aurora, and the rest of the Austin Health team who helped support the work undertaken for this project. I would also like to thank the Peter Mac team who have supported my research this year. And thank you to those of you watching online for your attention. A question and answer session will now follow in a live session, providing I've made it to Brisbane without catching COVID. Thank you.